Welcome to another of the episodes of Judgment Date. We've been doing this for a long time now. We did it when COVID began because we wanted to try to explain to people what was going on with regard to COVID, both economically, legally, and medically. We're many, many months down the road, and we thought it would be a good idea to sort of, as it were, recap some of what's going on, particularly for the elucidation of people in the public. Is so much fake news, and I mean that seriously, going on, that I thought nothing better than asking Professor Glenda Gray to come back and to talk to us about this. Glenda, thank you so much. This is, I think, the third time, and I'm very, very grateful. So I wanted I could start, because it's kind of unusual, you know, that actually I can talk to a proper expert as opposed to some of these ersatz people who think they know everything, but literally have never either treated a patient or alternatively don't even have any medical qualification. But be that as it may, let me not vent my spleen on them. Can I just ask you, what is the state of play now with COVID? I mean, are we stable? Are we moving into a new wave? How do things look in South Africa at present?
So until we have enough access to vaccines, or we have what we would call herd immunity, COVID infections will continue to occur in places like South Africa. So we're in what I would call an endemic phase. We can't eliminate a virus or a pathogen without having enough vaccine coverage or having enough herd immunity. And for COVID-19 or SARS-CoV-2, we don't know how much herd immunity we need to be able to control an epidemic. And we've never been able to really control an epidemic without a vaccine. So herd immunity by itself has never, ever helped eliminate, eradicate, or control an epidemic. It's always been in conjunction with a vaccine. And so in South Africa, unless we have adequate access to a vaccine, it's unlikely that we will be able to eliminate SARS-CoV-2 from South Africa. So where are we at the moment? So we in as I said, we would call the endemic phase, where we would continue to seep transmission in the community and unable to really control it. And so we're in various parts of South Africa, you will see upticks. And so we see an uptick both in the Eastern Cape. In fact, more than an uptick. You know, there's a lot of crisis on beds, and we see mortality rise a lot in the Nelson Mandela area. In Cape Town as well, we're starting to see an increase in hospitalizations, and we'll have to watch the mortality rates as well. And so as we move into the Christmas season, we will probably find that there'll be various outbreaks of the epidemic in various parts of the country, particularly in areas where there's been less exposure the first time around. And so that's very important to understand, is that as people move from urban settings into rural settings, they are likely to put elderly people at risk, particularly if they themselves have got COVID-19. And so we'll see during the Christmas season, unless we practice physical distancing, wearing masks, hand hygiene, upticks of outbreaks in areas that weren't affected in the first time around.
So let me ask you this: a number of things that you've spoken about in the now. So let me try to unpack it. I mean, firstly, let me just talk about this herd immunity stuff. I mean, there seem to be all sorts of people. I don't want you to necessarily talk about who they are, but there seem to be all sorts of people running around saying, actually, almost Trumpian-like, all we need is herd immunity. But the truth is that that's not going to happen, as I understand you saying. I mean, it's not, without the vaccine, you can't get that, or you're unlikely.
Yes, yeah, I mean, I was doing a review this morning about how do you control, eliminate, or eradicate a pathogen that's caused an epidemic. And it's quite clear that none of these epidemics have been controlled without the use of a vaccine. And so it's unlikely that herd immunity itself will be able to control the epidemic. And so you need a combination of things. You need, obviously, good coverage of a vaccine. So even those who are susceptible will be protected by the massive coverage, or you need a combination of good coverage and high rates of exposure. Now, there have been high rates of exposure in South Africa. We know that in Khayelitsha, looking at a convenience sample of pregnant women and people who were HIV infected, up to 40% of of these people had presence of SARS-CoV-2 antibodies in them, and also we know that doctors have been heavily exposed and nurses. And so even with this high level of exposure, we still continue to see outbreaks in parts of the country that were heavily affected the first time around, namely the Western Cape and the Eastern Cape. So clearly, even though we had a lot of exposure and a lot of covert infection in the first wave, this still has not been enough to decrease the transmission that's happening at the moment.
Could I ask you just on that though, in the sort of, if I could call it the posher areas, which of course overlay, unfortunately, with our old apartheid spatial geography, which is just disgraceful, but that's for another occasion. There seems to be less, I mean, in other words, it seems to me that Khayelitsha got it worse than, let's say, Bishop's Court or Camps Bay. So does that mean that it's more likely that if there's a second outbreak in those areas which have had less of it, there's going to be a bigger exposure, a bigger outbreak?
That is what we expect to happen. So we were able to lock down. The middle class privilege allowed us to lock down in our homes. We weren't affected by finances or by overcrowding. And these households have are intergenerational and they have lots of young people in them. And these young people are khatful, are sick and tired of sitting around for months at a time and being contained at home. And so as the lockdown levels go down, they go out to clubs, they stop wearing masks, and they become involved in super spreading events. And we saw that with the tin roof, and we've seen it in other areas, and we've seen it also in Europe, is that there's a lot of epidemic or pandemic fatigue, a lot of mental health issues amongst youngsters, and the isolation is really affecting them. And so obviously they do go out, they drink, and they lose their inhibitions, and before you know it, the middle class home is affected. And this happened even to me. I have a 27-year-old daughter. She went to a festival and came home with COVID-19. And so it's evident that the people that weren't affected the first time around will be affected the second time around. And this is what I'm scared about, particularly in rural areas where villages were literally secured in the first wave. And now when people go home to rural parts of South Africa or go home to Malawi or Zimbabwe or Zambia, could fuel transmission in these areas during the December period.
So could we, I mean, Europe has had this astounding second wave. Is there a danger that we could get back to, those sort of levels of 13, 14,000 infections a day unreported? I mean, they're probably more. I mean, or is it going to be, are we, even if we get a second wave, it's not going to be quite the same as what we experienced in the first outbreak?
Well, I worry about winter in South Africa. And if you have a look at what's happening in Europe and North America, so even though the US was never ever contained, and that's for lots of reasons, the lack of using masks and disregard for social distancing. But if you look what's happening in Europe in winter, cases have gone up, and in the past they were, they had a huge epidemic in their previous winter. But it's also important to know that because these cities and countries were able to lock down, the exposure during the first wave was much less than we saw in South Africa. And so most in Spain and France, I think around between 9, depending on where you look, around 10% of people were exposed in the first wave. And so obviously they're more susceptible to being vulnerable in the second wave. However, having said that, in South Africa, even though overburdened and overcrowded townships may have been exposed the first time around, there are a lot of areas in South Africa that escaped the first exposure, and so are still susceptible and vulnerable to community transmission.
So we can't afford another lockdown if we get to that. So what would we be doing then, assuming we get into, I mean, the Eastern Cape's already in the position, presumably, where one should have stricter measures, I would imagine.
South Africa can't afford another lockdown, and that's that's quite evident in the kind of recession we face ourselves and the recent downgrading of our country. So we have to we know what does work, and we know that non-pharmaceutical interventions work. And these are rudimentary tools, but they're robust, and they do protect people. Wearing a mask, if you are COVID positive and you're wearing a mask, you breathe the virus into your mask and you minimize the transmission around you. If you wash your hands and you keep your distance, you're more protected from exposure that may be in the air. And also, if you're in well-ventilated areas, you're less likely to be affected. So we have to use these rudimentary tools. These are our barriers against transmission, and we have to continue to use them, even though there's pandemic fatigue. People are tired, it's summer, and they've had a hard year. And so the first thing they want to do is forget about the very tools that got them through the first wave. And so we have to continue to reinforce this and try and understand what are the barriers. There is a lot of misinformation out there that's saying that COVID-19, SARS-CoV-2 is not a severe infection. You don't have to wear a mask. And that is dangerous, because even if young people who may be asymptomatic get the virus, if they transmit it to older people in their households, there could be devastating consequences. I've seen, we know that in South Africa, with our comorbidities, even 50-year-olds and 60-year-olds are likely to be infected as compared to maybe the kind of demographics you see in Europe. And so you as a young person may get SARS-CoV-2 and you may have a mild infection or mild disease. But if you transmit it to your elderly parents or grandparents, it could have devastating consequences. And so we have to be mindful of those people in our community and those people in our households who are not as strong and young as we are.
Just out of interest, is it only the comorbidities that sort of explain why some people get very ill, or do we not know? There's a
lot of, the data is evolving and the science is evolving. And obviously exposure and the amount of virus you're exposed to, the contagion you're exposed to, has been associated with more severe disease. So that's one factor. So a huge exposure and a huge viral load will indicate a severe disease. But we also know that people with comorbidities, obesity, hypertension, diabetes, have done less well than people without comorbidities. And in South Africa, there is people with HIV infection are slightly more likely to have adverse events than people who are HIV negative or HIV infected people who are on treatment and well controlled. And so we do have comorbidities that other parts of the world don't have. We also have TB. And so we have to be very careful. We see a lot more morbidity and mortality in younger age groups in South Africa as compared to the UK or the US or Europe.
So, I mean, it's interesting about that. Shabir Mahdi, your colleague, when I interviewed him some weeks ago, he was expressing the view that whilst he's sort of pretty sort of similar line, of course, can't have a lockdown, etc. But things like pubs and crowds of 250, etc., that one may have to reconsider those if it got worse.
I think it is crazy to be in a non-ventilated, overcrowded area, and I think that owners and people who manage these areas have to be vigilant and have to enforce physical distancing, wearing masks, and making sure that the area there's good sanitization, hands are being sanitized, and people are looking after themselves. And so everyone has a role to play, and if we all play our role together, we can keep our economy open and we can keep our restaurants and bars open. Overcrowded areas with no ventilation are a dangerous area, whether it's a place of worship or whether it's a place of drinking. You have to be incredibly careful if you're going into large areas with lots of people and there's no ventilation and no one's wearing masks.
It's just out of the mask. I mean, the interesting thing is, just now that I find when I, for example, just a walk on the beachfront, for example, 3-4 months ago, almost say 80% of people would be wearing masks. Now, I accept, Marty told me your probabilities in the outdoors like that are pretty low, and I accept that. But I kind of always wonder that with sort of people wandering around without masks, one way or the other, there, whether there's an inference that can be drawn that generally they who don't wear masks, they are probably not wearing masks generally. That there's a kind of collapse of mask wearing in the manner to which we were wearing them, say, 3-4 months ago.
Yeah, it should be habitual. It should become, like you brush your teeth or floss your, it's like flossing. It should, or wearing your seatbelt. It should be a reflex reaction. And I take the point that when you are exercising or doing extreme exercise, then obviously wearing a mask is problematic. But if you are walking in public and you are going to shopping malls or you're going to restaurants, you should be wearing a mask, and that mask will protect others from you if you happen to have COVID-19. And so I think it's imperative that it's about showing respect to the fellow citizens, particularly those who are more vulnerable. You don't know who you could infect next, and so therefore it's about showing respect to your neighbor.
So can I then get on to the absolute sort of the key question, the vaccine? So where are we with that? I mean, it appears that many of these pharmaceutical companies are reporting 95% efficacy rates in other parts of the world. So the question, I have a series of questions for you, but number one, we're part of this venture, are we not? And the vaccine, we were in the Oxford vaccine, as I understand it, or am I wrong?
So wonderful things have happened this year. So the year has taken a nice turn, knowing that we have efficacious vaccines that are very highly efficacious. And South Africa has been involved in a number of vaccine trials. The ChimpAd trial, the Pfizer one, the Novavax one, and now the Ad26 J&J one. And later on in the year, in early January, a Sanofi Pasteur one, and then further vaccines. So we have been very lucky to be involved in these trials because it's given us an experience with it. And in some instances, the vaccines that we have been tested, the companies are offering not-for-profit prices. And so it is feasible that if our regulatory authorities and our governments work closely with the pharmaceutical companies that are involved in trials in our country, we could get access in a reasonable time. And so now is the time to start negotiating with the drug companies. Now is the time to look at what are the benefits and what are the side effects of global financing mechanisms like COVAX. And so we need to know volumes, and we need to know how to distribute them. We also need to make sure that we get access to vaccines that obviously don't have cold chain requirements like the Pfizer one, which requires -70. We obviously need vaccines that can be stored in bar fridges or at room temperature in order to get them to the rural areas of our country. And so then the biggest thing that's going to happen is obviously trying to secure doses, access, and distribution. And hopefully South Africa will be one of the countries that can leverage its position to get access early.
So let me just ask you about that. I mean, just the regulatory framework. I mean, presumably so one reads about the fact that these vaccines in the United States are going through regulatory controls as they are in Europe and everywhere else. We've got to do our own regulatory assessment. Is that right? I mean, do we have to do the same thing? Be satisfied that these vaccines?
Yeah. We have bilateral agreements with other regulators like the FDA and regulators in the European Union and in the UK. So there is collaboration and there is discussion across these regulatory authorities. And then obviously we have WHO, the World Health Organization, that will evaluate it and also look at pre-qualification. And if there is pre-qualification, it's a way of getting access to a vaccine faster than if you were working as a regulator by yourself. The fact that South Africa has had experience with these vaccines in clinical trials will also make it easier and faster to register a product in our country. So I would imagine South Africa would use a multi-pronged approach. It would work with other regulators, it would work with WHO, and it would use its experience in the country to expedite an approval process.
And have you any idea what timelines we're talking about here?
Well, I would hope that in terms of the Astra, now that we have, so the Pfizer vaccine would obviously is a complicated vaccine, and hopefully our country is having discussions with them. But that would be the biggest challenge because because of its cold chain requirements. But now that we have AstraZeneca, the ChIMP-Ad, the Chadox or the Oxford vaccine that's been shown to be efficacious and has less refrigeration requirements, it's the time to start talking to these companies. And as far as I know, AstraZeneca has entered into other relationships with other agencies to make the vaccine in other parts of the world, which increases availability. The AD26 J&J study, we know that Aspen in East London, in the Eastern Cape, has got has secured the ability to fill and finish in its facility in East London, which will then also help us increase access to the J&J study. But the J&J study has started, and we're about a quarter of the way through enrollment, and will only have results towards the end of January, and so that might be later in the year. But we should already be starting to negotiate with AstraZeneca, given that we have invested a lot of time and effort in evaluating the vaccine in South Africa, and so that would be our first point of interest. Moderna, on the other hand, although it's a highly efficacious vaccine and has good refrigeration ability, this is a US company, and they have had no real interest at this moment in time in making this vaccine available to anyone else besides high-income countries.
Typical. But I mean, you're saying that at least with some of these companies, they've got I mean, there is now a lot of pressure, isn't there? I mean, even the G20, I mean, people like Angela Merkel, who seem to have an unusual politician, namely someone with a conscience, actually is pushing the idea that the developing countries also get sufficient access to these vaccines.
Yes, a lot of these vaccines, besides Pfizer, were funded by the public purse, by taxpayers, mostly US taxpayers and European taxpayers, and so there should be benefit to the public, and there should, we should make sure that it's public good and there's not too much profiteering involved. But you might see a situation, which normally does happen, is that the high-income countries get them, the low-income countries get them, and the middle-income countries kind of are left out or expected to pay as much as high-income countries for the vaccine. And we saw this with our HPV vaccine, where South Africa is not a Gavi country, and so we didn't get affordable prices, and so had to procure at a different price model. And so we have to be careful that the countries that need it the most, like India, Brazil, and South Africa, who have huge epidemics, are not left out or not expected to pay American prices for the vaccine in their countries.
And can I ask you this? I mean, if we, assuming, because it's clear that presumably in some of the vaccines by January, they will be up and running in parts of the world. How would we, I mean, do we have the ability in this country to distribute these vaccines once we get?
Yeah, I mean, I think that...
Two questions. One is the manufacture, and then two, the distribution. Sorry.
So the manufacturing, obviously one needs volume. And when there's limited volume, then there's gating of access. And even in countries, you'll have to prioritize certain parts of the population. So normally what would happen, because the healthcare workers are the frontline workers, so the healthcare workers should get first access to a vaccine to protect them as they look after people with COVID-19. And then the second group that should get vaccine next are the elderly and people with comorbidities. And then obviously it's important to get kids back to school. And so vaccinating, understanding how the vaccine works in children to get them back to school and to get kids back into university is important. We also know, as we know, that in this, a lot of the spread will be caused by young people as they go out and refuse to, as they get pandemic fatigue, and having them vaccinated will protect households as well. So they're an important component of access to vaccines.
And will we be able to, but I mean, would we, assuming we got, well, firstly, just one aspect about the manufacture. I seem to think, I was looking for it again this morning, that the president, when he made his last speech, spoke about the Johnson & Johnson vaccine. Is that the J&J one that you're talking about?
Yes, yes, yeah.
That's a
So
little
that's the
later down the
one.
line. Yeah.
That's towards the end of January, early February. So that's down the line. But at the moment, so we need, the more vaccines we've got access to, the more affordable it'll be and the more volumes we'll have. And it may be that our first procurement may be for healthcare workers, and the second procurement might be a different vaccine for different parts of the population. The question you ask about how do we get it out here
Yes.
is how do we scale up a massive deployment of a vaccine to people that don't normally get it? So normally beneficiaries of vaccines are young babies and children, and they're easy they work in EPI. They get administered in EPI clinics and immunization clinics, and there's a whole understanding and acceptance of vaccines in young infants and children. How do you roll out a vaccine to adults and the general population? And there'll have to be mass immunization campaigns. There'll have to be workplace distribution, and there'll have to be a whole lot of programs to get vaccines to rural communities, to areas of the country where we wouldn't normally get it, and also mass vaccine deployment even in urban settings. Going into a community and with the vaccine and do mass vaccination campaigns, and that is how we're probably going to have to do it. We'll probably learn from the US as they grapple with this. So even well-resourced and more resilient health systems are going to struggle to deploy a vaccine at scale in a rapid time, in a manner that has never happened before, particularly if there are cold chain issues and there's vaccine hesitancy as well.
Then just, as you speak, I sort of start thinking, because, these are issues that we should be not just thinking about, but putting in place already, because we know that the vaccine will come at some point. And have you any idea whether any of this is now being thought through so that, in a sense, if it's not at least seamless, it'll be speedier than our usual implementation of a whole range of issues? In other words,
various scientists are thinking about how you do scale up and how you do what we call implementation science or operational research. So basically testing how you would do this, simulating it, and starting to plan how you would deliver a campaign for mass vaccination. And that starts with, first of all, obviously, community preparedness, building trust in the community, good communication and good media programs. And then obviously the next step is making sure that the vaccine can get to the community with cold chain storage, and that you don't affect the potency of the vaccine. And then the delivery will require needles and syringes and human resources that can administer the vaccine. And so the quicker we know how well these vaccines work in all population groups, irrespective of comorbidities in the elderly and in pregnant women, the better, so that we can deliver without having to pre-screen people for any comorbidities or ailments, and be able to deliver the vaccine in a rapid way. When we gate, in the beginning, there will be a shortage of vaccines at a global level, and so obviously there will be a prioritization, and we have to make sure that we get it to the people that need it first, and that is healthcare workers. So that might be the easiest deployment in the beginning, because we know where healthcare workers work, we know where to find them, and they understand vaccines and are less likely to be hesitant about receiving it. And then the next step is to get to the elderly and mechanisms of bringing in the elderly. And then the next step would be schools, universities, and the general public.
So my final question, because I'm running out of time. You spoke earlier in the interview about your anxiety that when we get into winter, we could get into serious trouble. So do you have a sense that by the time we get into winter, which are around about, say, June next year, that we will be at least in a position where the vaccine will be available to some of these constituencies, say healthcare workers or comorbidity people?
We have an obligation in South Africa to get the vaccine to the healthcare workers in this country. They have been tremendously affected, huge amounts of morbidity and death amongst the healthcare workers. They're the people that go out and care for people who are sick. And so our first obligation is to get them the vaccine so that they can be protected. And then our next obligation is to get it to the people who are more likely to die or get severely affected by COVID. And that is the elderly and people with comorbidities. And then afterwards, important strategies like getting kids back to school or kids back to university, immunizing them will also protect the greater population. So you have to do a targeted response. But if we don't have a vaccine for our healthcare workers by winter, that would be a tragedy in South Africa.
Okay, well, probably I can foresee us actually having another conversation about this. But thank you so much, because I've unfortunately run out of time. There are many other questions I wanted to ask you, but this is extraordinarily helpful. And as usual, thank you for being so accessible and putting it in words that people can understand. So
Thanks,
terrific.
and wear a mask in December.
I certainly will be. Take care.